good afternoon, good morning to everyone. My name is Nadia Al Mazrouei. It's my pleasure really to moderate this session. Our session, it's about pharmacists' contribution to epilepsy care in emergency situations. We will have a very valuable speakers. They will discuss these subjects, and it is in the today is the International Epilepsy Day. So our event is in the same day. So I would like also to see that there will be pharmacists play a vital role in multidisciplinary management of epilepsy, particularly in emergency situation, where timely and accurate intervention is crucial. So in the context of an epilepsy emergency, such as a status epilepticus or seizures-related crisis, pharmacists contribute significantly to ensure the rapid availability and the correct administration of anti-epileptic drugs, providing drug information and also monitoring for optimal drug interactions or adverse events. Their expertise extends to adjusting dosing based on the patient-specific factors, advising on medication protocol, and also educating healthcare team and patients on appropriate therapeutic strategies. Additionally, pharmacists often work closely with emergency medical personnel to optimize a drug regimen and prevent long-term complications, making them integral to improving outcomes and enhancing patient care during epilepsy-related emergencies. Their proactive involvement ensures the patient receives timely, safe, and effective treatments, ultimately reducing morbidity and mortality associated with epilepsy crisis. So we are here, we'll have few announcements for you that the webinar, it is recorded and also live streamed via YouTube. The recording also will be available in our website, www.events.fib.org. You may ask questions using the question box provided. You are welcome to provide feedback to webinar at fib.org. .org. Also become a member. We encourage you to become a member of FIB and at www.fib.org /membership registration. We are all here member, and we welcome you all here also to our situations. Also, new translation features on Zoom is available also. You can turn on capture, first step 1, turn on captions, and also step 2, enable the translation to goal. Choose the preferred language under my caption language. Also, now you can also follow along with live translated captions. Next, please. So, epilepsy care in emergency situation collaboration. This is done through the FIB Humanitarian Program, Pharmacy section of the International League Against Epilepsy. Next, please. Yeah. So we would like also none of our speakers would like to inform you that none of our speakers have conflicts of interest on the topic they are presenting. And also, we will tell you that our learning objectives is to define seizures and epilepsy, identify risk factors for seizures and epilepsy that occur in emergency. Also, we want to determine appropriate use of the anti-seizures medications in emergency, develop alternative epilepsy treatment strategy during medications. We want also to educate patients and healthcare professionals on emergency preparedness related to epilepsy from the point of intra-professional collaboration. Today program, we will first lecture or first speaker will be Tim Welty. He will speak about the importance of epilepsy care in emergency situations, and then the next speaker will be Stephen Norman. He will speak about pharmacists' involvement in emergency crisis response. Also, the third topic will be basic of caring for people with epilepsy. Dr. Robert Kuroski and Mara Taube they will speak about it. Then the fifth one will be alternative medications and administration routes when medication are in short supply. And this is Cecilia Johnson Landmark. She will speak about it. Then we will do some moderated discussion and some Q&A. Then we'll wrap up and conclusion by me. I will try to summarize for you the session. Next, please. So I would like to welcome our first speaker, important Timothy Welty, neurology medication management pharmacist and professor Emeritus UnityPoint, Health and College of Pharmacy and Health Science at Drake University in USA. Our first speaker, he will speak, Dr. Timothy Welty. He will speak about the importance of epilepsy care in emergency situation. Let's welcome him, welcome our professor for our first lecture. The floor is yours, Timothy.
Thank you, Nadia.
Welty?
Yes.
You're welcome. Thank you.
Thank you, Nadia, and welcome to everybody. We're excited to present this presentation, and I want to say good morning, good afternoon, good evening, wherever you are located in the rest of the world on this very important topic. So let me jump into this. Why are we talking about epilepsy care in emergency situations, and trying to give you a little bit of background and explanation for the rest of the topics we will talk about. So why is emergency epilepsy important to recognize? When we look at the global burden of epilepsy and the impact of epilepsy, minimally, and this is a very conservative estimate, there are 50 to 70 million people with epilepsy in the world. And you can see about 4 to 10 per 1,000 people in the world will have epilepsy. And what's really important to note about these statistics from the WHO is that about 80% of those people with epilepsy live in low and middle income countries. In the next couple of slides, you'll see where emergencies and disasters occur, and most of those occur in low and middle income countries. So it greatly impacts people with epilepsy. There are about 5 million new cases of epilepsy every year worldwide, and about 140,000 deaths every year due to epilepsy. And I think it's important to note, especially in this topic, in this context, that about 8% of people worldwide will have at least one seizure sometime during their lifetime. So this is a very, very important topic for us to consider. When we look at where do conflicts, where do crises, emergencies, disasters occur, these are a couple of maps. The one on the left highlights the current conflicts that are going on in the world, and you can see them scattered across many parts of the world where there are low and middle income countries. So where there are a lot of people with epilepsy in war situations or wartime situations. When we look at crises, emergencies, disasters that are occurring worldwide, this map on the right kind of gives us a view of that. And again, many of these are occurring in parts of the world where there's a high prevalence and high incidence of epilepsy. So many people that have epilepsy are impacted either by war, conflicts, or crisis, emergencies, and disasters. Currently, you can see this is what the World Health Organization lists out as emergency situations. There's a number of places, COVID-19, cholera, mpox, which impact us globally. But then there are a number of different countries, and many of them are low, middle-income countries where these emergency situations are going on currently in the world. And maybe some of you are in some of those countries, so this has great relevance to us today. So the other thing that we need to think about is how many people are impacted by these emergency crisis situations, and how many people get displaced because of emergency situations. So the WHO estimates that there are about 281 million international migrants. Now, some of those individuals, or many of those individuals, are migrants out of choice. They, due to economic reasons or whatever, are moving around to different places, either within the country where they live and exist, or internationally seeking jobs and job opportunities. So they are not forcibly, due to disasters or war, forcibly left to leave their home. They choose to do so, but they are migrants, and we need to think about them. But when we drill down and specifically think about emergency situations, there are about 82 million people who are forcibly displaced from their homes. And again, that's either due to war, due to disasters, due to other crises or emergencies. About half of them, or a little more than half of them, are internally displaced, meaning that they are living in the country that's their home country, but because of whatever, because of a disaster, they had to leave their home and move into maybe a refugee or some type of shelter situation because their home was compromised or destroyed. There are 26.4 million refugees who are displaced outside of their country. So they're going to a refugee center, maybe to a neighboring country or some other country that is willing to take them in because of the crisis disaster that they're facing. And then there are about 4.1 million who are seeking political asylum because of the situations in their home countries. If we just take statistics and work out the statistics based upon the incidence and prevalence of epilepsy, and assuming that this is true throughout all displaced people, there are nearly, and I would say this says at least 800,000 displaced people with epilepsy. I would say probably easily, based upon the fact that many of these crises and emergencies occur in low and middle income countries where there's a higher incidence and prevalence of epilepsy. At least I would say 1 million people worldwide who are displaced have epilepsy. Some of those may not have been diagnosed because they had poor medical care in the country where they were, or the area of the country where they were forced out. They come into a place where there's greater medical care and they may be newly diagnosed with that. So at least 100,000 or more displaced people every year are diagnosed with epilepsy. So this is not a small factor. And if you think about the numbers, this is similar to other disease states like HIV and other medical problems that are common among people. So I want to step back and just make some definitions. I know that later in the presentation, we'll talk about a little more of these definitions, but I think it's helpful to all of us to really understand what is epilepsy, what are seizures, and what are are psychogenic non-epileptic seizures, as launching us into this introduction. So an epileptic seizure is a transient occurrence of symptoms that are associated with abnormal, excessive, or synchronous neuronal activity in the brain. So a seizure involves abnormal neuronal activity in the brain. And I think it's important for us to remember that, because we'll see in a second something that appears like epilepsy, like seizures, that does not involve abnormal neuronal activity. What is epilepsy then? And epilepsy is really the tendency for unprovoked seizures. And the official definition of epilepsy means that a patient has greater than two or equal to 2 unprovoked seizures, epileptic seizures in 24 hours, or 1 unprovoked epileptic seizure with a risk of 60% of another seizure occurring, or they have a diagnosis of an epilepsy syndrome. And we won't talk about that very much, but it's something to consider. The other thing to consider related to epilepsy, seizures and epilepsy, is the classification of seizures and epilepsy types. So there are really 3 classifications, and I would say 2 main ones. There's focal onset epilepsy, which starts in a small area of the brain. It may spread, but it starts in a small area of the brain, or a focal seizure starts in a small area of the brain. There's generalized onset seizures, which involve the entire brain from the very beginning of the seizure. And then there's unknown onset. We just can't classify, is it focal or generalized? And under focal or generalized, there are different types of seizures. There are focal aware seizures, so the patient is alert and awake during the seizure. There's impaired awareness, where they have a loss of consciousness or impaired awareness. And then with generalized, there can be motor and non-motor types of seizures. The other thing that I think is very, very important to consider in this setting, in emergency situations, is that there are events that people experience that are psychogenic non-epileptic seizures. So clinically, symptomatically, the patient looks like they are having a seizure. They may have all of the symptoms that we associate with an epileptic seizure. But when we look at the brain waves, when we look at neuronal activity in the brain, there's no abnormal neuronal activity. So these type of events are occurring on a psychological basis. And many times they're related to emotional, physical, or sexual abuse or trauma. And you can imagine that in disasters and emergencies and crisis situations, emotional, physical, and unfortunately even sexual abuse and trauma is relatively common, and it can occur fairly frequently. So that is of a concern to be able to distinguish between psychogenic non-epileptic seizures and true seizures, because the treatments for them are very different than for true seizures. The other thing that we have to think about are risk factors for seizures and epilepsy. There are several fairly well recognized seizure triggers that occur very commonly in epilepsy. So missed doses of medications. Many times studies have shown that patients will go for 2 weeks, many times without access to medication. So there's a lot of missed doses, and people with epilepsy, if they miss their doses, they often will have a seizure. Sleep deprivation. These people are fleeing from very difficult situations. Their lives are upended, and so sleep deprivation is very common, and that's a common trigger for seizures. Stress. These are very stressful situations, and many people are sensitive to those stressful situations, and those can cause seizures. Alcohol intoxication or withdrawal. Many times, especially during war or prolonged disasters and emergencies, people unfortunately turn to alcohol to treat or medicate the trauma that they're feeling, and alcohol intoxication or withdrawal can be present in seizures. And then febrile illnesses, people get exposed to a lot of different diseases, a lot of viral infections, and can develop a febrile illness, which can trigger seizures. If we look at risk for developing epilepsy, there are many of these things that are present in emergencies. Traumatic brain injuries, many times people will be injured and have a head injury, and that's a risk for the development of epilepsy. There's an increased rate of infections that occurs. Actually, malnutrition is a risk factor for epilepsy, and people fleeing from disasters or in war situations may have difficulty accessing food and may become malnourished. Poor prenatal or perinatal care, so pregnant women who are caught in a disaster or in a war may likely get poor prenatal or perinatal care. And then obviously undiagnosed epilepsy, those people that have been in remote areas, maybe not been diagnosed with epilepsy, and then they come out and receive good medical care and then are diagnosed with epilepsy. So thank you for listening. I hope this sets a background of why this topic is so important, and we'll look forward to our discussions later.
Yeah, thank you very much, Doctor, for your very informative lecture. So we know a lot about the classification, about the seriousity, and also about the prevalence of the so now we want also to speak about I'll present for you our second speaker, who's pharmacist involvement in emergency crisis response, Dr. Stephen Norman. He's a clinical pharmacist from Orlando Health and Orlando Regional Medical Center in USA. He will speak about the pharmacist involvement in emergency crisis responses. Thank you very much. The floor is yours, Dr. Norman.
All right. Can you hear me?
Yes.
All right. I don't see my picture. So anyway, thank you to Dr. Welty and the program organizers for allowing me or inviting me to participate in this program. Good morning, good afternoon, and good evening to all of the attendees. It's a little bit about my background. In addition to being a clinical pharmacist, I have a background in clinical toxicology and a great passion over the last, maybe 10 years or so in the pharmacist role in disasters and emergencies and what their role is. So I'd like to start off by three basic steps that keep you safe during a natural disaster. And this is from the US Centers for Disease Control. Have an emergency supply kit, create a plan with family and friends, and keep up with local alerts that might be happening if it's weather or some other situation or scenario. Epilepsy, for patients with epilepsy and your need to have preparedness or be prepared is to keep your medications with you, have a medical alert bracelet or other ID with you, and to identify a family member, neighbor, or friend to help you in an emergency. And if possible, know what triggers your seizures. So pharmacists, community pharmacists in particular, but hospital pharmacists and others as well, have a regular contact with patients that may be suffering or have experienced a minor injury. And I think that pharmacists can do a really good job in providing information regarding first aid and how to treat whatever might be ailing them as a result of a minor injury or minor illness. We'll talk about in a little bit about what happens when you have a major event. And this slide really represents the fact that there are over 300 hazards in various categories. And there's a couple more slides that talk about this as well. So we live in a dangerous world. There's lots of things that can indeed happen. And so the hazards that have been identified, again, this is by the United Nations Office for Disaster Risk Reduction. So as a clinical toxicologist and with the interest in disaster preparedness and response, the cluster that involves chemicals and biological agents is of particular interest to me. You can see some of the others, and they're going to come up on another slide as well. This was a recognized area, at least in the United States, of what the major priorities were: extreme weather disasters, pandemics and emerging infectious diseases, physical attacks, cyber attacks, supply chain disruption and corruption, and then space weather. Recently, at least in the United States, we've been dealing with cyber attacks and also issues associated with supply chain disruption and corruption. And so that really affects what pharmacists do and some of the challenges that they have in taking care of their regular type of patients and scenarios that happen. And in cases of disaster, it obviously would be even more complicated and more significant. So again, the ideological descriptions of disasters, man-made, kind of mentioned, we call them subverting, which is chemical, biological, radiation, nuclear explosive. The incidents or situations of rioting or civil unrest, mass shootings, failures of dams, mechanical or structural problems, transportation disasters, and mass gatherings would be those that are man-made. And then natural disasters, you can see the list: earthquakes, fires, floods, heat, hurricanes, landslides, and so forth. So these challenges are what keeps folks make the awareness of being prepared for disasters. So there's in the disaster cycle, there are 4 different areas. Prevention, that's a mode that we should try to be in all the time. And then also associated with that is being prepared to assess the threats and vulnerabilities that exist in our communities, in our world, to the impact that it might have on businesses, to develop plans and procedures, to have training exercises and rehearsing what you would do, drills and tests and exercises before an incident happens. And then in the area that I work in, that happens on a regular basis, maybe a couple times a year. Major training exercises take place. When an event happens, it requires an assessment of the incident, determining the level of response, whether local responders can take care of that, or if it's something that requires additional help from other sectors, whether it be the private sector or from the government. Activating teams and plans, and that then there are various categories within that response mode. And then after that, it's a recovery mode where people are either rebuilding their lives or rebuilding their properties that they were damaged and so forth. And then the cycle goes on. Hopefully we're learning from the scenarios that happened and then moving on to, or unfortunately waiting for the next disaster to occur. So just some pictures or examples. The hurricane on the right is close to where I live. The picture of the earthquake is not something we don't worry about in Florida. show you this picture because the building on the right, this is somewhere in the Midwest of the United States, the building on the right is a hospital. And when hospitals become victims of disasters, then that really compounds the whole scenario and the way that we hope things work, where hospitals and emergency teams are available to help out. So they are not immune to the disasters. Global warming or climate change, whether it's extremes of heat or extremes of cold, are something that also complicates the impact on the medical community when you start having record high heats, not only in metropolitan areas but throughout the world. So another slide on that talks about the various kinds of things that are related to climate change, rising temperatures and rising sea levels and more extreme weathers that we're seeing throughout the world, and the various kinds of complications that they can cause, and the challenges for all health professionals, including pharmacists. So again, another depiction of the phases of a disaster, and it's the preparedness phase that is super important. So know what the threats that exist in your area. Work with your local health professionals or disaster preparedness professionals, and be ready to respond when an event happens. And again, it should be a learning situation where people are taking the things that happened and try to improve them as in terms of being prepared for the next event. So just a couple more pictures of mass casualty or disaster situations, transportation accidents, the train wreck with chemicals involved, and so forth. The middle picture there of a mass gathering, either that's some kind of music festival or some other kind of maybe a sporting event. And then the picture on the lower right is one that I worry about sometimes. I know that other toxicology and disaster medicine specialists are concerned about this as well. And we didn't really talk about it on the list, but those that have nefarious intent, using drones, for example, spraying nerve agents over a large crowd at a soccer game or football game could result in hundreds or thousands of victims. Some of the football stadiums in America are maybe 50, 60, 70, 80,000 people. So that kind of event would be catastrophic for everyone. The medical community would not really be able to respond in any fashion, or at least it would be extremely challenging. So I include this based on the comment that I just made about the impact of the medical community, is that when you have a mass casualty where you have lots and lots of victims, hundreds or thousands of victims, there's I believe, a universal triage system where patients are indicated as red, yellow, green, or black. Black patients are those that are dead or have a minimal chance of survival, and resources are typically not used with those patients when you have other patients that can be helped. So a red patient is one that has a really, really serious, massive hemorrhage or massive injuries that require immediate care to save their life. Those are the patients that are taken care of first. The patients in the yellow category are those who can wait. They have serious injuries, they can wait. And the green patients are significant, I think, for pharmacists, because we know first aid. We can provide help to our patients and help and assist them with those minor injuries, and take some of the burden off of the other parts of the medical community. So here are some pictures of a hospital with a mass casualty incident. I believe that the upper left-hand corner is the hospital that I work in. And I think that might have been for a drill. but you can see that the hospital emergency rooms are very, very busy. These are pictures of medications that are used in various disaster scenarios, whether it be through a NGO or through a government program to be able to provide life-saving medications and others, including patients with epilepsy, providing them the medications that they need. Picture of this is a federal team in the United States. I serve on one of these teams that are deployed for usually 2-week periods to various disaster scenarios in our country. And other countries have those as well. This is the Strategic National Stockpile that is in the United States, and the transport of material in the event that it's needed in a particular area of disaster. Pharmacists are, when a disaster occurs, and they're taking care of those red patients and the yellow patients. And again, you may not even be able to get into an emergency room. Pharmacists can help those patients with minor injuries. They can help with them with their prescriptions if they've been displaced from their homes. So this is a combination of I think a cooperation between an agency and a private pharmacy. And you can see some other places where pharmacists are providing assistance to members of their community. Picture of a place where folks can go to seek refuge. This could be an issue because if you have a patient with epilepsy and they don't have their medicines, they may not be available at this location. They may be they may have to go outside and get the medication. And depending on what's happening in the community, what kinds of disasters have taken place, that may be easy or not. So again, for the patients that are minor injuries, this is, and many places in the world, the pharmacist is the most accessible healthcare professional, and their ability to provide first aid advice or preemptive advice. So, do you have a backup supply of your medications? Patients with epilepsy or diabetes or other chronic conditions, are they prepared? And what would they do if there was an emergency in their community? So the pharmacist's role in disasters and emergencies, supply of prescription and over-the-counter medications to provide first aid for those green triage patients or your everyday patients that need some advice or help from the pharmacist, to triage them and refer them, and also psychological support, sometimes referred to as psychological first aid. And so community pharmacist teams interact with 1.6 million people every day throughout the world. And pharmacists have a really significant role. One comment, I talk to my colleagues a lot about at my hospital about us being prepared. And I provide some of the scenarios that I mentioned to you, and I often hear, that'll never happen. And I shake my head and say, that'll never happen until it does. And we need to be prepared for worst case scenarios so that when something happens, that we can help those in need. So thank you very much.
Thank you very much, Dr. Norman, for this nice presentation. I think you cover a very good topic of the role of pharmacists in disaster management, and I think you clarify what will be the pharmacist role. It will be limited to green triage patients or supply of OTC and some of the medications. Thank you very much. Really, it's very informative. Now I will introduce our third speaker, Dr. Robert Kotelski. He's an assistant professor at William S. Middleton Memorial Veterans Hospital in University of Wisconsin's School of Medicine and Public Health, Department of Neurology in USA. He will speak about the basic of caring for people with epilepsy. Also share with him Maralena, Dr. Maralena Taube Kuroski, clinical pharmacist practitioner at William S. Middleton VA Hospital in USA. Thank you very much. The floor is yours. Thank you. You can start. Thank you very much. Prof. Yeah. Yeah, now I can hear you. Maralena?
Yeah, so sorry about that. Hi, everyone. No. We are excited to present on pharmacist contributions to epilepsy care in emergency situations, focusing on the basics of caring for people with epilepsy. Dr. Kotlaski is our clinic epileptologist, and I am the clinical pharmacist within the Madison VA Hospital Outpatient Epilepsy Clinic. So I will pass it to Dr. Kotlaski to begin, and then I will end our presentation.
This is just a map here of a VA system here in the US and where we're located, this hub and spoke system. Let's see, oops. Next slide. Yeah, I guess maybe we don't have control. We have talked about this a fair bit, the definition of epilepsy and a seizure. You know, the way I explain it to patients is anybody who has a brain can have a seizure, right? You live at this seizure threshold over on the right with that graphic. You live at a certain distance from that, you can have a provoked seizure in the upper right-hand corner, right? All the kind of things that we talked about, infections and stress can move you closer to that line. And what epilepsy is that you live closer to that seizure threshold line. So they're crossing it on a more regular basis. And again, things like stress and malnutrition, all of those kind of things that may happen in a crisis situation can move that line closer for everyone and for people with epilepsy. Next slide. Do you have control? Do we have control? Well, there maybe do. When I see someone in clinic, the basic management, they come in with some event, and the first question we try to answer is, was that event a seizure? And that is done through clinical history and trying to put everything together from the patient and the rest of their medical history. Another question is, was it their first seizure, as we had with the definition of epilepsy, right? And talking about seizures, 8–10% of people will have a seizure at some point in their life. They don't have epilepsy. They don't need necessarily additional epilepsy care. But if you find out they came in for a seizure and actually that wasn't the first one, that was the second, that was the third, and just the one that finally got them medical attention, then they do need epilepsy care. If we can find an etiology that is useful, that's maybe half of epilepsy, where we have all the tools to try to figure out what's going on and give them a diagnosis of epilepsy and a particular kind of epilepsy. Next on the list is teaching the patient and the family, right? There's often a lot of misinformation that people have, a lot of biases that they bring into the clinic. To talk to the family, talk to the patient, help them to understand their diagnosis, what it means and what it doesn't mean, so that they can be, as we'll talk about later, part of the team and do a good job taking care of themselves. Is treatment needed? Again, this may be, was the event really just a provoked seizure versus epilepsy? Sometimes there is enough doubt about that first question, was it a seizure, that treatment is not necessarily begun at the beginning. But in most cases, by the time they get to us here in an epilepsy clinic, we err on the side of treatment. And then the question is which medication to use. Hopefully in many situations we have lots of choice. That's not always the case. But if so, what medication? And then is additional referral needed to either confirm the diagnosis or explore treatments other than kind of medication treatments for epilepsy. To talk briefly about treatments, right? So a lot of the treatments for half, 3/4 of people with epilepsy. There are anti-seizure medications, medications that work primarily on synaptic transmission that you all know as good as I or better. For most people, these are how we treat their epilepsy, focusing on that medication. When those medicines don't work, again, this is not a small number, but maybe 1/4, 1/3 of people with epilepsy, we think about other options like surgical options, removing the bit of the brain for those focal epilepsies. If we can identify it and have a surgeon who can remove it, open techniques, there are always less invasive techniques that we develop. There are devices that can be used, various kinds of neuromodulation, including older vagal nerve stimulations, and then newer devices like a responsive neurostimulator made by NeuroPace, deep brain stimulators like are used for Parkinson's disease. These are useful treatments for people where the medications don't work, either because the seizures aren't controlled or because the side effects are intolerable. And then lastly, too, I'll mention metabolic therapies, right, as a kind of a second line, at least therapy, something different than just intervening at synaptic transmission, are useful for many people with epilepsy. As we've been focusing on it, as for this talk, what we'll mention, right, epilepsy management is interdisciplinary, right? The patient is at the center, right, and their caregivers, family should be there. There's epileptologists and trainees along those lines, but also pharmacists, MARA, nurse practitioners, nurse case managers. There are many people involved in kind of optimal care, as needed, these people get involved. Our goals, though, for treatment are no seizures, no side effects, no adverse effects, and to do that as soon as possible. And that's what this interdisciplinary team shoots for. Again, this has been covered before, but epilepsy care in a crisis setting is obviously more complicated. Not something we have a whole lot of experience, although recent COVID pandemics, we have a little bit of that at some level, but certainly things like increased stress and then disruptions in healthcare. So for most people with epilepsy, the #1 cause, the most likely cause of a breakthrough seizure is not getting their med, right? When the situations are good, that's they don't request a refill, or it doesn't get to them, or something like that. If there's a disruption in healthcare, obviously there can be many other causes that are not so easily fixed that can lead to those breakthrough seizures from not getting your medication. We talked about traumatic brain injuries leading to both acute seizures and post-traumatic epilepsy. The tools that I've talked about that we like to use, that again in optimal settings, things like EEG and those surgical treatments may not be available, and we have to work around that. In epilepsy, there is status epilepticus, these seizures that don't last a few minutes but continue. Those could be very difficult to manage without these tools, without the right medications and the right environment. It can be deadly, as we talked about deaths from epilepsy earlier. I will talk briefly, we will cover some more. The essential medications on the WHO list include several anti-seizure medicines, several benzodiazepines that can be used for clusters of seizures or prolonged seizures. Again, this is not our full list from that slide before, but for patients with well-controlled epilepsy, there's probably reason to think that if you don't have the medicine they were on before, you could essentially switch them in a situation, as sometimes, fortunately not very often, but sometimes we have to do here. That is likely okay for that group that are well controlled. For those people with difficult to control epilepsy, though, it may be a challenge to use these medications. The last thing I will mention, kind of epilepsy in a crisis setting, something that we use at the VA that you could see from that map with the broad geographic range that we have, and then at various points when face-to-face visits have been excluded but not available, is to use telemedicine. And I think in epilepsy, fortunately, a lot of what we do can be done by telemedicine, that we can talk to people, talk about, do you have seizures? Anybody else report the seizures? What do your side effects look like? Much of that could be done over the phone. If you have video, too, right? You can look and do some subset of an exam, and I think deliver relatively good epilepsy care in those situations. Not perfect, certainly not as good as face-to-face, but I think I'll pass it off to Mara. Speaking of collaboration.
Yeah, I will talk a little bit about partnership and collaboration, specifically focusing in on how a pharmacist can be involved many different ways, but I'll focus on a few, be involved in caring for patients with epilepsy, and talk a bit about our clinic here that we're sitting in today. It's a pretty well-oiled, collaborative clinic. There's been a pharmacist present here since 1991. So within the federal VA healthcare system, some pharmacists could have a title of a clinical pharmacist practitioner, or a CPP. And basically what that means is it's some additional training. So you go, you have your PharmD and then 1 or 2 years of residency. And we are able to work under something called a scope of practice to prescribe independently, prescribe medications and monitor them and manage them, so long as they fit under the umbrella of our scope of practice. So for me, one of my scope of practice includes epilepsy. And so under the epilepsy umbrella, if it's an anti-seizure medication or specific monitoring or labs or side effect follow-up, I'm able to kind of manage that. But again, our clinic team, you saw the circle of everyone who's involved. We are very interdisciplinary, and we really lean on each other and kind of talk through cases and make sure we're all on the same page when making these medication decisions. I just wanted to pull a few slides of statistics within the VA healthcare system in the US. These numbers here are up to date as far as September 30th of 2023. So we're missing 2024 data. But as you can see, the graph indicates basically appointments that a pharmacist has held within the US, and specifically looking at neurologic conditions. So you see epilepsy is listed. And with time, more and more clinical pharmacists are being involved in neurologic care. If we look within our specific VA outpatient clinic here, I pulled data from all of 2024, and the number within the triangle indicates how many visits over that year that specific provider held. So we have neurology residents and fellows. We have a lot of pharmacy residents come through. This is one of their required rotations for their residency. We have 1 nurse practitioner. We have Dr. Kotlaski, who is our epileptologist. And then we have 2 clinical pharmacist practitioners, myself and Barry Goodall. And so you can see, although there's 2 of us, like the numbers are a bit skewed, Dr. Kotlaski definitely holds his own. But we see a lot of the follow-up patient visits. So we do see a lot of, we see a lot of the patients and help with getting patients in sooner. Sometimes our availability looks a lot different than maybe Dr. Kotlaski's availability. And so I'm decreasing wait time and increasing access to care. This is just a list of a few different types of interventions that a pharmacist within this clinic could make, and certainly outside of this clinic too. So we have dose adjustments, increasing anti-seizure medication doses or decreasing them, managing side effects, stopping a medication or starting a medication. Again, most often we will kind of collaboratively talk about that with the team before just kind of making big med changes, but definitely within the scope of practice to do so. Lab monitoring or checking levels of anti-seizure medications, checking in on adherence, and then referrals to other clinics within our healthcare system. So we screen for sleep apnea, we screen for mental health. If someone has a tremor, for example, from a side effect of one of their anti-seizure medicines, we can send them to physical therapy. A lot of the older anti-seizure medicines can cause osteopenia or osteoporosis, and so we check in on bone health and send patients for DEXA. So really looking at the patient as a whole, outside of just epilepsy management as well. So I talked about our VA health system, which is very specific to the CPP or clinical pharmacist practitioner in a scope of practice, but this model also works very well in the private sector too. So I specifically have pulled out the Cleveland Clinic. So they have one full-time ambulatory epilepsy clinical pharmacy specialist. She started in August of 2022, and she works under something called a collaborative practice agreement or a delegation protocol, which is much more common in the private sector than the umbrella I talked about of the scope of practice. And so a CPA, for those who are unfamiliar, it is a legal agreement between a pharmacist with an authorized practitioner, typically an MD, whereby the pharmacist may perform certain patient care functions or modify drug therapy. So it can be as strict as the pharmacist and practitioner want it to be, or as broad as they want it to be. So it could be, any anti-seizure medicine, the pharmacist can adjust the dose, or it can be as strict as the pharmacist may order lab values for these 5 meds. So it's really up to the pair to decide what works for their clinic. So if we look at the Cleveland Clinic and what that ambulatory care pharmacist does, 30% of it is anti-seizure medication management, so adjusting the doses is within their delegation protocol. A new anti-seizure medication, if it started, they can the MD can send it to the PharmD, and they can kind of continue with the titration, adherence, education, working with women with epilepsy, and then cenobamate management, just due to a lot of drug interactions. They send a lot of those patients to the pharmacist there. So it's not just within the VA health system that in the US that pharmacists have a big role, it's also in the private sector as well. And then finally, I just want to comment on community pharmacists. I know there's been a lot of discussions about their role in emergency care, and I'll just add, of course, education, side effects, drug interactions, medication interventions, checking that the patient has the correct dose. Consistent supply is really important, and then emergency supply. If the patient maybe doesn't have any refills left and they can't get a hold of their provider, a lot of community pharmacists are able to provide an emergency supply. And then finally, seizure action plans. So maybe the community pharmacist has a stack of blank seizure action plans and goes through it with the patient to fill out what their meds are, if they have any emergency meds, basically telling anyone around the patient, if the patient has a seizure, what do you do? So that is it for our presentation. Thank you so much for having us.
Well, thank you for your presentation. Thank you. It's very also interested, and I think we get a lot of knowledge by this by our eminent speaker. Next, please. Now we will also have for our next presentation, Dr. Prof. Cecilia Johnson Landmark, professor and medical advisor in Oslo Metropolitan University and the National Center of Epilepsy and Department of Pharmacology from Oslo University Hospitals, Norway. So she will share her experience also about the alternative medication and administration routes when medication are in short supply. This is a very interesting topic, really. Thank you. The floor is yours, Prof. Cecilia. Thank you.
Thank you very much. Thank you for listening to everyone for this webinar, and thank you also to the organizers for this invitation to participate. So I will share some experience from Norway regarding short supplies of medicines, and also I will discuss with you alternative medications and also routes of administrations when we need to switch. And I will refer to also a recent publication on that. So our background, I'm from Norway. It's in the northern part of Europe, so it's another part of the world. We have a National Center for Epilepsy for more than 100 years. We have a lab for clinical pharmacology, and I will come back to what we can measure when it comes to anti-seizure medications. And we have a pharmacology team that I'm lucky enough to lead on, which is an interprofessional approach to contribute to comprehensive care for our patients. And we have national surveillance of short supplies of medicines that has been increasing in recent years. So next slide, please. So short supplies of medicines for epilepsy might be temporary, as all these cases of shortage of medicines, which luckily enough often are short-term, and it may not impact the individual patient. We might have alternative suppliers and also alternative drugs or forms of administration that I will show you. But of course, this might be much more difficult during crisis or during times of war when it comes to supply logistics and also how to use alternative medications. Also, there might be constant short of supply in low-income or resource-poor countries around the world. And I will also mention to you the WHO list of essential medicines and how we might use drugs in a rational way for those we have available. These are some of our experiences from Norway when it comes to critical or potential shortage of anti-seizure medications from 2022 to 24. You see to the left the number of various cases that we had each year, critical, potential, and also those not shown to not to be so relevant, because very often the patients or their caregivers, they scream that they cannot get access to a drug, but possibly it's available after all. So we have to handle all these kinds of cases. As you see below, there are various drugs and also various forms of routes of administration that have been in short supplies, like clonazepam, phenytoin, valproate, sprinkles, oxcarbazepine, vigabatrin, etosuximide, also diazepam, clobazam, nitrazepam, and stirupentol. So a variety of various drugs that are also used in specific indications that I will come to. At the bottom, you see that very often we get information or questions from clinicians or from patients, and our pharmacology team, we try to collaborate with the National Collaborating Center for Medicines Shortage, but very often we have the first-hand information about these shortages. They also communicate with the Norwegian Medicines Agency, and they also together with us have direct contacts in the pharmacy chains through suppliers and also international contacts to try to solve these cases at an international level very often. And also we have the responsibility for dissemination of information and give all the clinicians and the patients updates through our websites and so on, so that there will be also quick responses to when these cases are actually solved. But sometimes it might take several months before we can get the proper medication back. So it's a challenge globally, actually. So these were some of our experiences. This is the WHO model list of essential medicines, and you see to the left that there is a variety actually of anti-seizure medications that are listed here. Also, there's an asterisk on levetiracetam. It has been recently included. While on the other side, you see the sorry, this is right. The International Emergency Health Kit, on the other hand, we only have at the moment phenobarbital and diazepam, and this list has obviously to be updated because it includes only 2 drugs that are there now. So this needs an update. So there should be more balance between the 2 lists, I would say. So this includes both drugs for prophylactic use and also for acute treatment of seizures. Next, please. So in this report from the International League Against Epilepsy, there was a task force working on recommendations for treatment strategies in people with epilepsy during times of shortage of anti-seizure medications. And you see here our colleague present today, Team Welty, was a part of this. And you see to the right the key points that there are possibilities switching between different anti-seizure medications, often those who are quite similar chemically, and also it's often easy and accessible to switch between a brand to generic, or also between generic formulations of ASMs, and sometimes also between different routes of administration. So we'll look at some examples. Some easy switches between similar ASMs are like oxcarbazepine and eslicarbazepine at given ratios, and both these drugs are very similar again to carbamazepine. Clonazepam and clobazam are very similar benzodiazepines, even though clonazepam is much more potent than the other one. Primidone is actually a prodrug for phenobarbital, and these might be switched. Levetiracetam and brivaracetam are based on the same chemical structure, and brivaracetam is a more new substance with more potency. And of course, in other cases of switches, we should be aware of patient-specific factors, pharmacokinetic interactions that are often occurring, and also various generic formulations. To the right, you can see a table with a kind of benzodiazepine bridge, where they have summarized various relevant benzodiazepines that are often used either in acute seizures, but also sometimes during prophylactic treatment of epilepsy, like for clobazam and clonazepam, while diazepam and lorazepam are more used in acute situations. When it comes to routes of administration, of course, it will depend on what's available, but some switches that are quite common would be to switch between extended release tablets to immediate release, like for carbamazepine or valproate. In many countries, we most commonly use extended release, but sometimes if an immediate release tablet is available, we will have to switch for a period. Tablets to mixture is possible, both in children and adults, like for valproate, levetiracetam, and there might be also other drugs. Here, the pharmacokinetics will be a bit different, but otherwise it's a quite easy switch. And also from buccal to rectal administrations during acute seizures for midazolam or to diazepam is sometimes to be recommended when like midazolam is not available. Next. So also we have careful considerations to have in mind when it comes to specific groups of patients with severe or also more rare epilepsies, like in infantile epileptic spasms in very young children. Vigabatrin and prednisolone are 2 drugs that are often used, and it might be critical if they are not available. For rare syndrome like Dravet syndrome, there are specific drugs that are used like valproate, stirupentol, and clobazam in combination, and also now available in many countries the newer drugs like cannabidiol and also fenfluramine, which are more specifically used in such syndromes. Another syndrome is Lennox-Gastaut syndrome. Often here combinations with valproate, levetiracetam, benzodiazepine like clobazam or clonazepam, and also new drugs like cannabidiol are used. When it comes to women of childbearing age, we should just remember to avoid valproate and topiramate regarding risk of birth defects and also cognitive and developmental delays and malformations, of course. So this has to be in mind. And for the elderly, when it comes to commonly used drugs of the new ones, levetiracetam and lamotrigine are often used, but we also had to take into account the pharmacokinetics that will change in this age group, and also the occurrence of various adverse effects that might be more age specific. You can click another time so we will see the whole picture. So this is just a reminder for the pharmacokinetics. When it comes to the more patient-specific factors or host factors to the left, all these factors relating to age, weight, ethnicity, genetics, physiological status, pharmacokinetic variables, and so on, these will affect the pharmacokinetics of each anti-seizure medication. And of course, if possible, we can manage pharmacokinetic variability during, for instance, changes between routes of administrations, or also during changes between generics to each patient's need. So by that, I will just thank you for listening.
Thank you for your presentation. Thank you very much. At least we are, each time we are adding a new information. And I think the WHO list of emergence of essential medication should be also updated, I think, because only 2 medications we said is available. So by my role in the WHO, I will ask them to update, because I am in the expert advisory panel committee. So this is a very important point that I can also reach it to the WHO during.
Yeah, thank you very much.
Yes, thank you very much. Actually, next, please. Yes. Now we will start our panel discussion with Professor Janet Mifsud, head of the Department Clinical Pharmacology and Therapeutics in University of Malta. So please, you can start. So if there is any question in the Q&A, yeah, there is a lot of
Yes.
them really,
Yes.
actually.
So
you'll start reading it?
Yes. Thank you very much, Nadia. Thank you for the panel, for those very interesting talks in the short time that we have had, just 1 hour. And I think it gave a very good flavor of the importance that pharmacists have in helping to manage epilepsy as part of the interdisciplinary team. And the comments I have seen in the Q&A, and I appreciate, and I thank already. I have seen some answers already coming up, both from Dr. Welty and also from Maralena, some of the questions. And it seems there is a big need among pharmacists to know more about epilepsy, because they are at the front actually of helping to manage care, whether it is not only in disaster settings or emergency situations as we are discussing today, but also in everyday role of the pharmacist. And if I may, I think I will start with Dr. Welty. Tim, I know you answered this question already, but this is something I think which is of interest to the audience today. Why is there no treatment to treat epilepsy totally? There are in fact a number of questions alluding to the different anti-epileptic, anti-seizure medication, rather, now we are calling them. And I'm very pleased to hear that Ms. Nadia is actually on the WHO board. This is an issue I've been discussing a long time to see how we can improve the list of anti-seizure medication and the essential medicines list. And there are many questions related, for example, to levetiracetam, to gabapentin, to phenytoin. Tim, can you perhaps expand on your answer which you gave for the benefit of the audience?
Okay, thank you, Janet. Just before I jump into my answer, a couple of notes. First of all, Nadia, I hope and we'd love to work with you on addressing the emergency health kit concerns with WHO. So we'll be in contact.
My pleasure.
Yeah. I just want to highlight, if people will go to ilae.org, there are two resources that I think would be helpful. First of all, there's a place for the pharmacy section on that website, and you can sign up to join the pharmacy section of ILAE, and we'd be glad to have you join. The second thing on the ILAE website, there is a whole webpage with a number of resources related to epilepsy in emergencies and disasters. The paper, the manuscript that Cecilia mentioned is on that website and a number of websites. So if you just go to ilae.org, you should be able to find all of those resources. In relationship to the question, I think it's really important for us to understand, and Dr. Kozlowski can highlight this too, that epilepsy is not a single disease. It really is probably more correct to describe it as the epilepsies. As we learn more about epilepsy, we understand that there's a lot of very different underlying pathologies associated with epilepsy, all the way from sodium channels to potassium channels to disruptions in neurotransmitters, a lot of underlying pathology that cause seizures. And so we have to think about, how do we treat that underlying pathology? And so there are a whole variety of medications that target the various causes of seizures and of epilepsy, number one, but oftentimes, at least at this point, it's very difficult to correct some of those problems. For example, if it's a problem with sodium channels, it may be genetically caused, and that is more of a permanent problem until we develop new technology, new treatments. And so we have to give the medications regularly throughout the patient's life to correct that underlying problem with the medications that we have. So I want to emphasize that we have to understand epilepsy as really being the epilepsies, and the underlying pathology varies from patient to patient to patient.
Thanks very much, Tim. In fact, there have been some questions as well about the pharmacogenetics, or are there any genetic implications with respect to epilepsy, and does this affect treatment and management, pharmacological treatment? Would anyone, perhaps Dr. Kuroski, would you like to answer that question?
Yeah, I will add just on to Dr. Welty. You know, I think there's a process underlying epilepsy too, other than seizures, that we don't understand well. And I think that's part of the reason we don't have treatments for it. That for any of, and I agree with the epilepsies, but really for any of them, I don't think we understand the process by which that genetic or other kind of insult leads to epilepsy very well. So that makes it hard to have a treatment. As far as pharmacogenetics, I wish that we had better information there. We have some, but you know, we saw those long lists. Again, in good situations, you have this long list of medications, and you make some choice based on primarily kind of you know, type of epilepsy a little bit, but often the side effects, good or bad, of those medications. But you know, right, you try one, it takes a while, and you try something else. I wish that we had some pharmacogenetics or some kind of susceptibility to say, look at their ion channels and help guide that. And at the moment, it's a lot of trial and error. Yeah, doesn't, I wish it had a bigger impact on epilepsy.
Yeah.
Is there anything to add,
Maralena?
Laura?
No, the only other thing I would add is as far as like the pharmacogenomics, my understanding is really as far as we have regarding anti-seizure medicines is just if the patient is maybe a rapid metabolizer in a specific CYP enzyme or doesn't metabolize very well at that enzyme, it could impact drug levels and just how the medication works in general. But that would be kind of as far as my understanding of where we're at with pharmacogenomics and anti-seizure medicines.
Thank you very much. There's another question which actually just came up, which I thought is very interesting. Speaking of epilepsies, is there any emergency management one can employ to manage epilepsy before actually giving the medications? Would anyone like to answer that question? Yes, Maralena or Dr. Kuroski?
Yeah, Robert's fine. So I guess would the question be in somebody who has epilepsy before you would
give the medication?
Yeah, I mean, I think there's a lot of education, and that, as Mara pointed out, is it's certainly important for the patients. It's a role that pharmacists are often helpful with. Sometimes I show up with a white coat or whatever. They're so anxious that they don't do a good job communicating. We don't communicate as well as we could. So I think education is certainly on that list. Kind of seizure first aid, what to do and what not to do. People, right? You don't put something in somebody's mouth. You do how to care for them, how to keep track of the seizures. A seizure action plan. Amara talked about that, and I feel strongly everybody with epilepsy they should have a seizure action plan. And sometimes it's just recording the events. Sometimes it's watching out for status. Sometimes it's calling the clinic or calling EMS when those things are available. But that seizure action plan is not always medications, but I think everybody should have one.
Indeed.
Yeah, and I would just add to that off of my slide, understanding triggers for seizures, and as best can happen, helping patients avoid those triggers for seizures. They can't be totally avoided, but if you can minimize them, the risk of seizures does decrease. And I think that's important to communicate with patients.
Thank you. I actually have a question for Dr. Norman about disaster preparedness. In low resource countries, which may have perhaps not be as resource intensive as the United States or even here in Europe, what is the minimum, do you think? What are the minimum requirements for any hospital to be prepared with respect to disaster preparedness, especially when it comes to a chronic condition like epilepsy, which, as we've heard, has to be managed very often lifelong? There is no cure as such for epilepsy unless there is some type of surgical intervention. It's just preventing the seizures. So is there any minimal requirements which perhaps can be implemented?
Yeah, that's a good question. I'm not aware for hospitals that there is a minimum requirement. I didn't include it in my talk, but I define pharmacist's role in terms of medications for the pharmacy department's role, that there are two types of drugs. There's disaster drugs, and then there's medical countermeasures. And disaster drugs are the ones that we use every day in trauma. It's antibiotics, pain meds, rapid sequence intubation drugs, and IV fluids and so forth. Countermeasures are the antidotes that would be used in something like a chemical attack and so forth. So to answer your question about are there minimum for patients with chronic diseases or patients with epilepsy, not that I'm aware of. And I made some notes here, I think for all three different areas. The community pharmacists, I think, need to counsel their patients to have a backup supply, and be aware that that they may not be able to get their medicines, especially if there's an impending disaster, of course you don't know about things that just happen. for clinical pharmacists in the emergency department to really appreciate, and normally they're handling trauma and that sort of thing, but they also need to know the background of pre-existing conditions and medications. And then especially for the response teams, whether they be NGO or governmental response teams, they're not going to be able to stock all anti-seizure medicines. Which ones should they stock? Because they have limited capability to to provide medicines. So those formulary decisions or considerations, I think, are important. I don't know if that answers your question or not, except that I'm not aware that we have any quotas in terms of meds that we carry.
Yeah. I think this would be a very interesting study, actually, to see what the different countries are doing and actually with the resources available, what can be done. Thank you very much. I have a question here, which I think Cecile may be interested to answer. It was very interesting to hear about shortage of medication, even in developed countries as Europe, because of the shortage of medication. So in fact, mine is a two-part question. One question is from me, actually. What causes the shortage of medication in Europe? What is causing the rest of this, the supply? And then we have a question here in the chat. Can the compounding of oral medications perhaps be an alternative to the shortage of anti-seizure medication, considering perhaps possible issues with the efficacy and stability of the formulations?
Well, to the latter question, yes, stability of various formulations might affect how long they will be available, of course, and also the storage of medicines. There have been some studies performed in some parts of the world where it's very humid or very hot, and we see that stability of various anti-seizure medications and their generics might be less well conserved. So that's an issue, and it's a difficult and tricky question to answer. The factors that contribute to shortage of medicines in Europe, but it will apply to many parts of the world, actually, because this is now a global challenge. And I guess this has been discussed when it comes to supplier chains, different factories in some parts of the world that will only add with some part of the content or some of the wrapping of the medicines, or some transportation issues or logistics. So there are so many different factors that have been over the years accumulating, so that now it's a global challenge to have enough and the right medications at all times. And also in some countries, one are now much more interested in making national storages and be more careful of having supplies for each country. But of course, then it might be an imbalance between countries as well. So this is very tricky and very unforeseeable. So we cannot know the next crisis or how long it will take. But I think from time to time there is almost always at least one anti-seizure medication that is very difficult to reach at all times, and we try our best to find various solutions, but it's difficult, especially in vulnerable and those patients and those with refractory epilepsy.
Indeed. Thanks very much, Cecile. I think I'm very much aware of the time. You only have a couple of minutes left. And considering looking at, we have people from all over the world attending this meeting, and I'm sure something which has come up as well is the fact about the role of perhaps alternative therapy, of modified diets, of herbal medicines, omega oils. Would someone like to give a comment on those, together with the traditional so-called Western medicine we are discussing today, anti-seizure medication, before we conclude? Tim?
I could try, Janet, and I don't know that I have a full answer. I think that certainly diet can play a role, especially in certain types of epilepsies, where the ketogenic diet may be a role, especially in young children, or a modified Atkins diet, trying to produce some ketosis, which can protect against seizures and can be helpful. I don't know that I'd recommend other types of diets, because obviously nutrition is a big, important role to play, has a very important role to play. So if anybody does a ketogenic diet or modified Atkins diet, really should be under the monitoring and care of a qualified healthcare professional who's familiar with those types of things. There's an important part for pharmacists in that, because they will make sure that there's not a lot of sugars in a preparation of a medication. So there's that. In terms of herbal products and that, I think there's a lot to be learned in that area. And a lot of research needs to be done to really understand what herbal products may be helpful, as well as what are the toxicities of those herbal products, and what are the potential drug interactions, especially with the Western type of medications that are used. And that is an area where there's opportunity for a lot of research and a lot of information to be gained that would be helpful. Right now, I would say we know very little about that aspect of caring for patients.
Thanks very much. Again, lots of food for thought, and I think this seems to be only the beginning of I hope will be an ongoing collaboration between the International League Against Epilepsy and FIP, and perhaps we can follow on with further webinars, because it seems there is a big need and a big thirst for more information about epilepsy. I'll leave it now to Miss Nadia to conclude.
Yeah, thank you very much, really, my dear. Thank you, Prof. Janet. Thank you for this. I would like first to thank all our participants who's really attended this very useful and interesting subject about epilepsy. We learn all from each of others. And I would like special thanks for also our speakers, all of them, for also delivering this very important information and for this nice discussion. Also, I would like to thank the FIB for allowing us to get together and to give this in this event, very valuable event, especially the military section, who's an humanitarian FIB humanitarian section committee, so that we are going to deliver. A special thanks for Robin and his team for helping us also to logistic all these things. Thank you very much for everyone, and we hope we will meet again in other functions. Thank you very much in other events. And check all the future events on eventsfib.org, which you will find very interesting. Also, we will welcome you all to join us on the 83 FIB World Congress in Pharmacy and Pharmaceutical Science, which will be in beginning of September in Copenhagen, Denmark, speaking about the pharmacy forward, performance, collaboration, and health transformation. And your presence is very crucial for us and support. Thank you.